It's being progress. What, Abdul is around?
Yes, sir, he's around.
Oh, Abdul, good evening. Happy New Year.
Sir, shall we start now, sir? I'll start.
Yeah.
Good evening. My screen is visible now.
Yeah, very much. I think, but you are not on slideshow. I mean, you are on slideshow. You should make it.
Yes, sir. Yes, sir. Good evening, everyone. A very warm welcome to all. I welcome you all to the very first session of this new year. I hope we can build on a platform that has been already laid in the last year. Today, the topic of Mondays are usually allotted for clinical lecture. And today I'll be speaking on understanding PVL and white matter injury of preterm. I'm Dr. Tanveer. I'm working as a resident at ICH in Chennai. I'll be speaking with the following objectives. What is encephalopathy of prematurity? What is PVL and what are its components? Etiology and pathophysiology, pathologic correlation, diagnosis and tools for prediction of neurodevelopmental sequelae. So with this background, let's begin with the first slide. That is, what is encephalopathy of prematurity? Now, during the early 80s, early 2000s, where they were trying to identify there was a substantial research going on to identify the pattern of brain injury in the preterm. They found that there was a gamut of findings and they were not able to put all the findings under one head. It was at this time that a very eminent neurologist, Dr. Walpe, whom we are all aware of, he proposed
Tanveer, slides are not moving, sir.
Not moving. Are they moving?
Not yet, sir.
Okay.
Not in slideshow.
Yes, sir. It's moving now.
So put on slideshow, sir.
Are they moving now?
Yes, sir. Yes, sir.
It is not in slide mode.
It's on my screen, it's on slide mode only. Now are they moving? Are they on slideshow?
In slideshow. Make it full slide show mode.
Yes, sir. I have put it on the slideshow mode only.
But it is not showing.
I'll close this in again. Sir, it's moving now.
No. Some problem I don't.
Okay, fine. I think I'm sharing the screen. I'm sharing the PowerPoint, not the screen. Now it's moving, sir.
It is okay.
Moving.
Yeah. So I think I started off saying what is encephalopathy of prematurity. So during the 80s to the early 2000s, when there was substantial research going on to identify what is the pattern of injury in the preterm brain, they found that there are plenty of tremendous amount of lesions, and they were not able to classify all these lesions under one head. Because at this time, that Dr. Joseph Volpe, who is based in Texas, Boston actually, he proposed the term encephalopathy of prematurity. This term was introduced to include all these abnormalities under this one head. If we look at it more carefully, we can say that this term includes lesions of the gray matter or lesions of the white matter broadly. So for example, the prototype example of a white matter lesion is PVL. A prototype example of a gray matter lesion is neuronal loss in the thalamus or basal ganglia. Thalamus or basal ganglia, I mentioned this because when during the autopsy studies, they have found that the gray matter which is most commonly involved in preterm brain injury is the thalamus or the basal ganglia. Now we know that white matter lesion is a predominant type of injury in a preterm brain, which is why PVL forms the core example of encephalopathy of prematurity. Then the next table I have taken from Volpe. It has enlisted all the lesions which come under encephalopathy of prematurity. We don't need to dwell too much into this. We just need to know that a prototype example of white matter lesion will be PVL. A prototype example of gray matter lesion will be what I just mentioned. So like I mentioned, the next objective was we'll be speaking about PVL. What is PVL? PVL is a central feature of encephalopathy of prematurity because white matter lesion is the most common lesion in the preterm brain injury. What does it literally translate to? Leukomalacia. Malacia, we know, is softening, and leuco is white matter. And in this context, there is softening of the white matter mainly due to necrosis of the white matter. And where is this necrosis happening? It is happening in the periventricular region. That is the white matter adjacent to the ventricles. Necrosis of the white matter adjacent to the ventricles is the literal translation of periventricular leukomalacia. Now, it's a fact that whenever there's an injury to the body tries to contain the injury. It responds to the injury. So whenever there is necrosis in the brain, how does the brain respond? It responds by what is called as gliosis. Because it is reacting to this injury, it is called as reactive gliosis. What is the meaning of gliosis? Gliosis is uninhibited proliferation of glial cells. We know there are 4 types of glial cells in the CNS. In this particular type of injury, 2 types of cells are predominantly proliferating. One is astroglial cells and second is microglial cells. Another couple of things that I need to make a mention of when I speak about gliosis is whenever gliosis is happening as a reaction to a necrosis, 2 things happen. Gliosis is more often than not associated with scarring of the brain tissue. Second thing is gliosis is usually diffuse. So if you look at it, PVL has 2 components. One is necrosis, which is usually focal, and then you have a diffuse component, which is a diffuse gliosis. Whenever there's a focal necrotic injury, this injury heals in 2 ways. This is a liquefactive necrosis, doesn't have coagulative necrosis, doesn't have anything to do with coagulation. It is generally happening in soft tissues because the brain is soft. So whenever this necrosis heals, it can heal with the formation of a cyst or without the formation of a cyst. So if you look at it, PVL is of the following types: focal necrotic cystic PVL, focal necrotic non-cystic PVL. Now, there sometimes you may have injury which is not severe enough to cause necrosis, but the injury is enough to cause white matter damage to the brain, and the brain reacts, or the injury is severe enough to cause damage to the brain, and the brain reacts to this injury in the form of gliosis. This is known as non-necrotic, non-cystic PVL, which is also described as diffuse white matter injury by some authors. So these are the types of PVL as such. What is shown in the left is the pattern of injury. Again, there are small annotations here which are describing the pattern of injury. You have small necrosis which has healed with cysts here. You have again lesions. I'll be describing these lesions in the coming slides. This is focal necrotic non-cystic type of PVL. This is non-necrotic, non-cystic type of PVL, which is also described by some authors as diffuse white matter injury. I mentioned the percentages here. Percentages vary depending on different researches, but they are more or less the same. Cystic type of PVL, which was predominant earlier, is only about 5% now. Necrotic, non-cystic is about 10 to 15%, and the rest of the lesions are all diffuse white matter lesions. I'll try to illustrate this slide for you. They put all the bits and pieces together. I'll try to make it simple as much as possible. You can ignore the percentages at some places and only focus on those things which I make a mention of, just to make it easier. Now, this was based on preterm infants having brain injury, which was studied on autopsy. So, if you consider just hypothetically, there were 100 preterm infants who had brain injury. If you look at the neuropathology, 6% of them had cystic PVL. About 10% had non-cystic PVL. The rest, all of them had diffuse white matter injury. How does this look on when you do a neuroradiology on radiological investigation? This obviously looks like a cystic PVL, which is about 5%. This appears as what I described here as small lesions. These are described as punctate white matter lesions on your MRI. This is what is described here, punctate white matter lesions. The rest of the lesions are, you only have signal changes on T2 weighted images, and that also not on every MRI. Not all MRIs pick up these signal changes, but if they do pick up, these are visible only as some signal changes, which are described by this acronym here, DEHSI, diffuse high signal intensity. Now, this cystic PVL was classified by a group headed by Dr. Volpe. They classified this as severe. They classified this punctate white matter lesions as moderate, and the rest of the lesions were classified as milder. This correlates with the clinical presentation that these preterm infants present at a later stage. For example, those with cystic, the last line here is presenting the spectrum of clinical features preterm with brain injury can have. They can have injury as severe as full-blown cerebral palsy, or they may grow up to have only mild cognitive or neurobehavioral changes. The cystic type of PVL, the infants with cystic PVL usually develop, which are classified as severe white matter injury, usually develop full-blown cerebral palsy, although they can develop anything in this list here. Most commonly, they develop cerebral palsy. Those with diffuse, which appear on MRI as only as signal changes, which are classified as mild or intermediate white matter injury, they can present with cognitive changes only, or they can present with hearing or visual changes. They can also present with cerebral palsy, but these changes are much more common. Now that we have a fair idea about at least some idea about what encephalopathy of prematurity is, and we know that PVL is a hallmark lesion in under encephalopathy of prematurity, the next objective was to study the etiology and pathophysiology. When we speak about pathophysiology, there are various anatomic and physiologic factors. In today's presentation, I've concentrated more on anatomic factors and less on physiologic factors. We have heard a lot of talks on cerebral blood flow and the physiology behind that, how it keeps fluctuating. So I'll not be speaking much on that. Let's focus a little bit on the anatomic part of the lesions, why they are predisposed to brain injury. Now, if you look at the density of the vessels, now this is a putamen, and this is your cortex, and this is your white matter. Look at the density of the vessels in the preterm between 24 to 32 weeks. Compare and contrast white matter density of vessels in the white matter to that in the putamen, basal ganglia, or that in the cortex. So the number of blood vessels, the amount of blood flow to the cortex is low. No doubt they are more the white matter in the preterm is more they're more predisposed to white matter injury, the preterms. The next thing is the next anatomic factor is the periventricular region is predisposed because it is called as watershed zone, also called as border zones. Why are they called as border zones? If I have to simply put it, they're called in simple terms, they're called border zones because only their borders are well perfused. See, you have two types of vessels supplying them. Some vessels, some of the arteries, which the middle cerebral or the anterior cerebral arteries, which come at the cortex, some of them give branches which run deep. These are known as long penetrators. And then you have vessels which are running short. These are short penetrators. These penetrators, initially in the preterm, they reach only the border zones. So these regions in the center are not well perfused. Another factor is the anastomosis. For some reason, if there is ischemia to one penetrator, you don't have enough anastomosis between these vessels so that the blood can flow from the short penetrator to the long penetrator. This anastomosis is established as the gestation improves. So less anastomosis and border zones make them predisposed to injury, make this region predisposed to injury. That is why it is known as watershed, means border zones. And the corresponding population of cells is shown here. You have pre-oligodendrocytes as a rich population of cells in this region. The significance of pre-oligodendrocytes I'll be telling in the coming slides. And also we are very well aware that this is a region where our corticospinal tracts are passing through. Now the this is the ventricle, this is the periventricular region. Periventricular region has during the development of the cortex has several layers. This is known as the subventricular zone. And then you have the subplate region, and then you have the subcortex, and then you have the cortex. This is the chronology of development of the brain. Eventually they go on to form a cortex, and then subcortex, and then the white matter. So this region immediately adjacent to the white matter is known as subventricular zone. The region which is labeled as GE is germinal end zone. Now, why I have made a mention is these are very close to your periventricular region. Germinal, this is the germinal eminence. Yeah. Most of the neurons of the cerebral cortex and the subcortical nuclei are originating in the subventricular zone or in the germinal eminence zone. And these are more prone to your injury. So when you have injury to these, your neurons will be affected in the cortex as well as in the subcortex. And like already mentioned, you also see that there are a lot of tracts, axons, which are passing through these regions. So this injury to this region will affect your axons as well as your neurons. I have put the slide. Yeah. Next to your this is your subventricular zone. Immediately adjacent to your subventricular zone is what is known as subplate neuron. I am mentioning all these slides because when you read Volpe or any other articles regarding pathophysiology, there will be a lot of tables. I'm just trying to make those tables easier by explaining these slides here. So immediately adjacent to the subventricular region is your subplate region. Now, this subplate region is important for a couple of reasons. One of the reasons is they form the pathway through which these are known as thalamocortical axons. Thalamocortical axons during the preterm brain development are passing through this region, and this is immediately adjacent to the subventricular region. So whenever you have damage here, there are very high chances that this subventricular region can get involved, and then your subplate region also can get involved. So what happens if this is involved? Your thalamocortical connections are not established. Your cortical as well as thalamic volume will be involved. Thalamocortical connections thalamus is the sensory relay station. So a lot of problems with developmental problems can happen when your thalamocortical connections are affected, which we will speak of again in the coming slides. Now, this is, I don't remember from which animal. You see in the 13th day, these are just handshaking each other. But when you see in the adult, there's an exuberant there's exuberant connections between all these axons. This is how they're usually found by the adult. Whereas in the preterm, if you get damage here during the preterm period, this connection is not formed. These axons go on in the cortex and they form associations between each other. They form cortico-cortical connections, and these fibers are known as association fibers. So whenever you have damage to the subventricular zone or to the subplate region, these axons which are migrating to the cortex and later form the association fibers are affected. Now, formation of association fibers is important because you want to integrate the information that is reaching your cortex. So these tables from Volpe become easier now that we know some pathogenesis of what are the lesions, what are the axons involved. This is the subplate region. Now I told you there are a lot of axons going here, particularly the thalamocortical connections. When these axons are affected, the axons don't develop, your cortex as well as thalamic development is affected. I told you in one of the slides that the white matter region is densely populated by one population of cells called as pre-oligodendrocyte. Again, this is the chronology in which your oligodendrocytes are maturing into mature oligodendrocytes, and they are causing myelination of the axons. Now, during the preterm period, the population of cells which is predominantly present in this region is pre-oligodendrocyte. And it is found that these pre-oligodendrocytes are extremely sensitive to hypoxic, ischemic, or inflammatory injury. Another important function of pre-oligodendrocyte is while they are wrapping around these axons and causing myelination, this process is also helping in your axonal outgrowth. So whenever you have pre-oligodendrocyte injury, both your myelination is affected as well as your axonal outgrowth is affected. So pre-oligodendrocyte injury, which will affect your myelination as well as your axonal growth. Again, your cortex and thalamus are affected. Other regions are also affected. Predominantly, your cortex and thalamus is affected. Same thing with the axonal injury. It is at this time during the preterm brain, whenever in the preterm brain, you have a large population, the other large population of cells is migrating GABAergic neurons, which are most sensitive to, again, hypoxic, ischemic, or inflammatory injury. Whenever there is injury to these neurons have been found to have a very critical role in the cortical development, particularly the uppermost cortical layers. So when these neurons are affected, again, your upper cortical layers where your integration of information is taking place will be affected. This is just to unwind yourselves. I hope I made sense in whatever I've spoken so far. That was the pathogenesis. Very briefly about etiology. Chorioamnionitis, we know, is one of the important predisposing factors for your preterm brain injury. So what happens whenever there is fetal infection, maternal or fetal infection or inflammation, this itself can predispose to prematurity. And whenever you have fetal inflammatory response syndrome, that itself can cause a diffuse white matter injury. This was the injury which I was speaking of, which is not severe enough to cause necrosis, but it can cause a gliotic response in the preterm brain. So chorioamnionitis is one of the factors which is predisposing to this. Also, premature infants, due to a lot of reasons which I just mentioned. We've just spoken about the anatomic factors, physiologic factors like fluctuating cerebral blood flow, pressure passive cerebral circulation. All these predispose them to ischemia, and our interventions can predispose them to reperfusion. Ischemia is associated with hypoxia and energy failure, and the ischemia reperfusion can predispose the preterms to IVH. Whenever there's energy failure or there is IVH, you have oxidative stress. Oxidative stress is nothing but your inflammatory injury which is causing white matter damage. White matter damage again has been classified as two types. Whenever it is severe, it is known as necrotic injury. Whenever it is mild, it is known as diffuse white matter injury. We don't need to go too much into these parts. This slide was just to mention that inflammation can cause, ischemia can cause, hypoxia can cause damage, your IVH can cause damage, and all the interventions which interfere with your cerebral blood flow can cause damage are all the etiological factors to cause to predispose a preterm to white matter injury. So this is important just to know that what are the interventions that we can do to minimize preterm brain injury, beginning with antenatal interventions. What all you can do to minimize the preterm brain injury. So we spoke about this is also explaining what happens with the hypoxia ischemia. When it is severe, you will have pancellular death. There is necrosis, which can or you can have, if it is not severe enough, it can cause pre-oligodendrocyte. Let's not confuse too much with this. This slide is just to highlight that your cerebral blood flow in the newborn is highly volatile, highly vulnerable. Try to use we need to use all the methods which can minimize the fluctuation in the cerebral blood flow. We are aware of that. It's a separate topic by itself. Before going into the clinical features, I put this slide just to show you that what are the white gray matter lesions which can be involved in a preterm brain. This picture I picked from Walpe, you see that the most commonly thalamus is involved, followed by your basal ganglia. Now, what is coming up, what has been studied extensively in the last few years, or what is coming up is your involvement of cerebellum. So you have neuronal loss, and this neuronal loss is compensated by the response. What happens whenever there is neuronal loss is gliosis. So common areas involved are thalamus, basal ganglia, your cerebellum, and your brainstem also. Speaking of clinical features, you need to know this slide before we speak about the clinical features. This is the periventricular region, and we know the most medial fibers are the fibers to the leg. Whenever you have an injury here, that is why spastic diplegia is the most common presentation. However, we know that the diffuse white matter injury is seen in about 80% of these lesions. So not necessary you may have a preterm who develops spastic diplegia. What they can develop is over a period of, you can have lesion here, you can have lesion here, you can have diffuse lesions involving all this. So these preterm infants can go on to develop mild motor disturbances which involve only the face, only the arm, only the trunk, which is why a neurodevelopmental follow-up becomes very important in these children. Now, because the injury to the preterm brain is very diverse, it is difficult to reach to find a clinico-pathological correlation. What I mean to say is, you are having a clinical finding in a preterm. If you go back and try to search what is the lesion in the brain, where is the lesion in the brain, it will be difficult to find one point because of the pattern of the injury is so diverse. Nevertheless, let's try to correlate something here. I told you that spastic diplegia is the most common involved because of the location of the corticospinal tracts immediately adjacent to the periventricular region or the watershed region. You can have motor deficits without spastic diplegia, like I already mentioned. You can have injury anywhere and you can have motor deficits in any part of the body. Then you can have cognitive deficits. I told you that these axons which were growing in the brain, they help in the formation of cortical connections, the association fibers, what I was talking of. Whenever your subplate region is involved, whenever your subventricular zone is involved, now these regions have a population of axons which are growing towards your cortex, and then they help in the formation of cortical connections. Now, no wonder that when these axons are affected, you are going to have cognitive effects. Now, you have what are known as visual radiations, auditory radiations going to the parietal cortex, and then you have the ophthalmic radiations which are going to the occipital cortex, and this is all white matter. You can have white matter injury anywhere. So you can have a preterm who develops cortical injury and can have vision affected, can have hearing affected, which is what is mentioned here. Attention deficits is something which we are looking at. They are looking at, and they are finding that there are a lot of ADHDs in the preterm infants when they are followed up, which is why screening at 18 and 24 months becomes very important to look for features of attention deficits. So what are the common motor disturbances? Again, this picture is again taken from Walpe. Just to give you an example of some of the motor disturbances apart from cerebral palsy, which they can develop. I told you cerebellum can be involved, your balance can be involved. You can have visual motor integration. Cortical connections are affected. So what is happening? Example of visual motor integration, which can be affected in preterms is, now they have found that these are some of the common some of the common presentations apart from cerebral palsy in children who were born preterm and had brain injury. Now, what are the visual motor problems they found in children? To give you an example of a visual motor problem, they will not be able to match these lines. This is just an example, just to make it easier for you. They will not be able to match this. This is an example of visual motor incoordination. They may have hand-eye coordination problems. Hand-eye coordination example will be you throw a ball at a child and the child has to catch the ball. You may have problems with this. Manual dexterity is your manual skills in performing different types of activities. They can also have difficulty in understandably running. You can have spastic diplegia. Drawing is an example of manual dexterity. They can have problems with coordination. Again, I have told you the clinical pathological correlation for this. Example of non-motor deficits in premature infants. Some of the cognitive deficits, behavioral deficits, we already spoke about the cerebral visual impairment. These are the non-motor deficits which can develop in these infants. So this slide I have taken, this picture is from Walpe. Again, the clinico-pathological correlation of these disturbances are multiple. Final inference in this is they have told that more data are needed to study to find clinico-pathological correlation in these lesions. How do you diagnose PVL? Now we know we need to use, this is a injury of the white matter. There's no blood test to do this. We can do it through an ultrasound, or we can do it through an MRI. Cranial ultrasound initially will be the initial modality to use to diagnose PVL. This is because many of the infants who develop preterm injury are usually intubated or on NIPPV or cannot be shifted due to many logistic reasons. Cranial ultrasound becomes a very simple tool to initially look for any features of white matter injury in the preterm brains. What are you looking for? I will not be speaking in depth because, as a matter of fact, I don't even know the details of cranial ultrasound. I'll be telling you, I can be able to tell you what we do generally bedside. What are we looking at? We are looking at the periventricular region. What are we seeing at? Echogenicity of the periventricular region, and we are comparing it with the echogenicity of the choroid plexus. If the echogenicity of the parenchyma is more than that of the choroid plexus, then PVL will be considered. Initially, in the initial few days, the echogenicity of the adjacent parenchyma may be more as a physiologic phenomenon. The persistence of this echo density for more than 7 days, if it persists for more than 7 days, then we call as grade 1 PVL. See, this is the watershed zone. The periventricular zone is also the watershed zone. This is where we are seeing persistence of echo density lasting more than 7 days. Now, this is a device classification based on ultrasound. Grades 2 to 4 have cysts. So this classification becomes more useful only for cystic PVL. Now, grade 2 to 4 is graded based on the size of the cyst. Here you have small cysts, here you have large cysts, and you have much larger cysts in grade 4. So ultrasound can help you pick up mainly cystic type of PVL, but cystic type of PVL is constituting only about 5% of white matter injury in the preterms, which is why the role of MRI becomes important in diagnosing preterm injury. What are the areas we need to look at? Which areas we need to look at when we are imaging the preterm brain? In the coronal section, you are looking at the superior regions and the lateral regions. And in the sagittal sections, again, you are looking at the posterior and the lateral regions. So what are we looking for? We are looking for echo density, and we are looking for cysts. Next few slides are just showing the echo densities or the cysts. I put up a picture already by DeVries. This is just to make it easier for you. This is grade 1. See the echo density here. This is more echo dense compared to the choroid plexus here. So this is grade 1. Again, this is more echo dense compared to the choroid plexus. This is grade 2 with small cysts in the coronal, both in the coronal as well as in the sagittal section. Now we say that it is said that we need to look at the findings both in the coronal as well as sagittal section before commenting that there is a change in the preterm brain. Before commenting that there is any lesion, for example, cysts, or when you look at IVH, we look at both the sections. So I've tried to put a picture which includes both sections, coronal section as well as sagittal section. Now this is grade 3, which is showing slightly larger cysts. This is grade 4 with much larger cysts. Now, the next thing is, how useful is an ultrasound? Now, there was a study which was published in the Neuroradiology Journal in 2003, and they studied the utility of cranial ultrasound and they compared it with MRI. What they found on ultrasound in 74 infants as a normal or transient echo density, at term they did an MRI in these individuals, and they found that only 48% were normal. 25% had white matter signal abnormalities, which were deemed as only as normal on cranial ultrasound, which is what I was highlighting. Your role of MRI becomes very important. Now, what was seen on ultrasound as prolonged echo density, 10 of them turned out to be normal on MRI at term. So ultrasound will not be the sole modality of choice. MRI is better compared to ultrasound in picking up findings of white matter injury or PVL at term. What are you looking for in MRI? This is something I already showed you. This is necrotic cystic PVL. This is punctate white matter lesion. See this is the cyst here. This is the cyst which is shown on the MRI on T2 weighted image. These are punctate white matter lesions which are appearing as white lesions here. And then this is diffuse white matter injury. See these slightly more white regions, what they have labeled through an arrow here. This is the diffuse white matter injury. So you're mainly trying to look at diffuse white matter injury on an MRI, because this is the most common type of injury, and this is the injury which is missed on your ultrasound quite often. These pictures are only to show the same thing. When I share the PowerPoint presentation, you can again go through these slides. This is again showing your punctate white matter lesions. This is the top of the brain view showing punctate white matter lesions here. Again, your punctate white matter lesions, slightly larger punctate lesions. This is your cystic injury. Now this is showing increasing severity of white matter injury. This is white matter injury is localized to this region here. This is more diffuse white matter injury. And if you look at this, this is much more diffuse white matter injury. These are signal changes. It's difficult for me to explain to you, being a non-radiologist, whether this is just a normal white matter or white matter injury. They have told that this is signal changes, which was labeled on this slide, that it was labeled that this was a signal change on MRI. And that was what is shown on the arrows here. Now, how useful is your MRI in predicting? We said that ultrasound is not very good. How useful is your MRI in predicting cerebral palsy later on? What is the utility of doing MRI at a term equivalent age? Now they found that MRI these percentages differ again depending on different neuroradiology journals. So I've tried to give you a range based on different journals. I can share the different journals where they have mentioned what is the utility of MRI at term. They found that MRI can pick up 85, MRI alone can pick up only 85, maximum to 88 in some studies. So there is a good chance you may miss up to 15, good chunk of patients which you may miss. You may label them as normal, but later they may go on to develop some changes, some motor deficits, or non-cerebral palsy deficits, some behavioral changes, some attention deficit problems, if you rely solely on MRI. They found, many studies have found that general motor assessment of general motor tone, what do we call that? But you can tell. Yeah. So you need to do HINE, that is Hammersmith Infant Neurological Examination, as well as general motor assessment, general movement assessment. Now they have found through various studies, and I'm just quoting a couple of studies here. They have found through many studies that in addition to MRI, if you use, if we integrate MRI with Hammersmith Infant Neurological Examination at 4 months, and general movement assessment at 3 months, you can improve the sensitivity and specificity of picking up a neurodevelopment problem later on by 97%. Again, on MRI, it's not just the presence of lesion which is important. Now, this was published again in a neuroradiology journal in 2019, where they mentioned that not just the presence of lesion is important, also the location of the lesion is important. You're looking at white matter volume is important. They found that when you integrate the location of injury, for example, lesions which are anterior are supposed to be more dangerous because the fibers are passing more closer here to the periventricular region. So lesions in the anterior part on MRI can predict more severe cerebral palsy or more severe motor disturbances. You may have a lot of white matter volume changes. One more thing, what I forgot to mention is, when you're looking at MRI, apart from signal changes, what we see is we may have some volume loss. Signal changes is not the only thing we look at. There may be volume loss which may not show as signal changes. When I say volume loss is for example, you may have changes, you may have corticospinal tracts being involved, for example, because these are passing through the periventricular region. Now you may have axonal loss in this region. This axonal loss may not show as changes in the white matter signal also. These may not be seen as signal intensity changes. So what do we do in those cases? Well, they have identified that we do what is called as a white matter tractography. This is done by an advanced MRI technique called as diffusion tensor imaging, which is not available everywhere. So That is one of the reasons why MRI is not very significant. So you need to look at white matter volume, which can be done by advanced MRI techniques. You need to look at location. In the clinical variables that they have mentioned in this study is you need to look at other predisposing factors that a child had, like PDA or BPD. Again, these can predispose an individual to. This can predispose this gives higher sensitivity. This improves your accuracy on MRI when you consider all these three. What are the difficulties? Why are we having difficulties in predicting the lesions in MRI? This is something which I already told. There may be some microscopic necrosis which may not be available, which may not be visible on MRI. You may have punctate white matter lesion, which these can be picked up early. But what happens with time is by term equivalent age, suppose in Preterm was born at 30 weeks, you're doing a scan MRI at 40 weeks. Sometimes these may disappear by the healing process, but they have caused some volume change, some tract changes, some axonal damages. This can be seen on MRI as normal. Again, we need to use advanced MRI techniques. Tracts cannot be picked up on MRI. So this is about the significance of MRI, various neurodevelopmental tools which are to be used. So I think I've covered most of the objectives that I mentioned in the slide. We spoke about encephalopathy of prematurity, PVL, idiopathogenesis, clinical features, clinico-pathological correlations. We spoke about the various diagnosis using ultrasound, MRI, and why we need to follow up with other findings like general movement assessment and Hammersmith infant neurological examination. I think that was about what I wanted to present today. I hope I have not bombarded you too much. Thank you all for a very patient listening.
Thank you, Dr. Tanveer. That was a nice, very lucid presentation. And whatever you mentioned were very good. And everything, whatever with regard to PVL, you just brought it out very clearly. The neuropathological variant, focal, microcystic, macrocystic, diffuse, everything you have elaborated very well. The watershed zone, end zone and border zones. And one thing, is there, can you just say, what is the relation between, that was actually mentioned in the slide, but it was not little highlighted in your presentation, I think. What is the relation between carbon dioxide level and PVL? Can you please just
answer? I just didn't concentrate much on the physiologic factors which are affected.
Yeah. As a clinician, we are much more interested in the clinical aspects of PVL rather than much. Yes, of course, whatever you told is very important to understand the pathophysiology. It would be very useful for the listeners' audience if you just say a few points about the carbon dioxide level and the relation between CO2 level and the PVL. And also, of course, IVH.
Yes, sir. Hypocarbia is known to cause cerebral vasoconstriction. Apart from it, the cerebral blood flow is known to be pressure passive, unlike pressure reactive in the older infants. So, the systemic blood pressure during which your brain will regulate the cerebral blood flow is very narrow. Whenever you have ischemia or reperfusion, this can predispose to ischemic damage.
Hypocarbia is related to PVL, and
yes, sir.
Hypercarbia is related to hemorrhage, right?
Yes, sir.
Intraventricular hemorrhage. Yes. And can you just summarize the some numbers we were all little hectic about the numbers. Can you just summarize prognostication? Hello, am I audible?
Answer.
Hello.
Yes, sir.
Can you just summarize in few words the prognostic value of MRI in PVL?
Sir, MRI, like I
So
mentioned.
we are doing MRI.
Yes, sir. Yes, sir. Like I mentioned in that the presentation, MRI, if we do MRI by term equivalent age, the percentages vary depending on different neuroradiological studies that they have done, sir. The sensitivity of an MRI picking up a lesion at term equivalent age varies from some studies, it's say 85%, some studies go up to 88%. So there is a good chunk of patients we may miss if we look at only MRI and we are predicting the further future neurodevelopmental sequelae. Like we say that see that MRI is normal and we counsel the parent that it is the baby is normal, it's neurologically intact. We may miss a certain chunk of patients, which is why it's important to ask them to come for a follow-up. And we look at general movements and we look at infant and Hammersmith examination at 4 months, 3 and 4 months. The sensitivity and specificity increases, and according to a lot of people, it increases up to 97% when you integrate all these three. The most sensitive among these three is said to be general motor assessment.
Hello.
Answer. Was I clear, sir?
Hello.
Hello, sir.
Hello.
Answer, I just spoke.
Hello.
Sir, I just spoke. You're audible. I just spoke. Sir, you're audible. I just spoke. I think that's about it. If nobody has any doubt with what I've presented, I think we can conclude it for now. Thank you all for a patient listening.